Ischemic heart diseases. Any of a group of acute or chronic cardiac disabilities resulting from insufficient supply of oxygenated blood to the heart, inadequate circulation of blood to the myocardium, usually as a result of coronary artery disease. Ischemic heart disease, or IHD, otherwise known as coronary artery disease, is a condition that affects the supply of blood to the heart. The blood vessels are narrowed or blocked due to the deposition of cholesterol plaques on their walls. This reduces the supply of oxygen and nutrients to the heart musculature, which is essential for proper functioning of the heart. This may eventually result in a portion of heart being suddenly deprived of its blood supply, leading to the death of that area of heart tissue, resulting in heart attack. As the heart is the pump that supplies oxygenated blood to the various viral organs, any defect in the heart immediately affects the supply of oxygen to the vital organs like brain, kidneys, etc. This leads to the death of tissue within these organs and their essential failure or death. Ischemic heart disease is the most common cause of death in several countries around the world. Atherosclerosis, next one. Atherosclerosis can affect any artery in the body, heart, angina, MI, and sudden death, brain stroke and transient ischemic attack, limbs claudication, and critical limb ischemia. And atherosclerosis, progressive inflammatory disorder of the arterial wall characterized by focal lipid-rich deposits of atheroma, then remain clinically asymptomatic until large enough to impair tissue perfusion, ulceration, and a disruption of the lesion result in thrombic occlusion, distal embolization of the vessel. Clinical manifestations depend upon the site of the lesion and vulnerability of the organ supplied. Then early atherosclerosis, second and third decades of life, tend to occur at sites of altered arterial shear stress such as bifurcations, starts with any abnormal endothelial function. Inflammatory cells, predominantly monocytes, bind to receptors expressed by endothelial cells, migrate into the intima, take up oxidized low density lipoprotein particles, become lipid laden macrophages or foam cells. As foam cells dies, it releases its inflammatory cells, predominantly monocytes, bind to receptors expressed by endothelial cells, migrate into the intima, take up oxidized low density lipoprotein LDL particles, become lipid laden macrophages or foam cells. As foam cells dies, it releases its lipid pool in intima space like cytokines and growth factor. In response, smooth muscle cells migrate from the media of the arterial wall into the intima. Lipid core will be covered by smooth muscle cells and matrix, forms stable atherosclerotic plaque that will remain asymptomatic until it becomes large enough to obstruct arterial flow. Early atherosclerosis, superficial endothelial injury, endothelial denudation, endothelium, plaque core, fat deposit, form cells, lymphocytes, phagocytes, smooth muscle cells, then fibrous cap, smooth muscle and collagen. Then thrombus, deep endothelial injury, plaque fissuring, superficial endothelial injury, endothelial denudation, deep endothelial injury, plaque fissuring, then endothelium, here we could say, plaque core, fat deposit, foam cells, lymphocytes, phagocytes, smooth muscle cells, fibrous cap muscle, smooth muscle, and collagen. Nomenclature and main histology. Initial lesion, isolated macrophages, foam cells, type 2 fatty streak lesion, mainly intracellular lipid accumulation. Intermediate lesion, type 3 changes, 2 changes and small extracellular lipid pools. Type 4 atheroma lesion, type 2 changes and core of extracellular lipid. Then fibroatheroma lesion, lipid core and fibrotic layer of multiple lipid cores, and fibrotic layers are mainly calcified and mainly fibrotic. Then complicated lesion, surface detect hematoma, hemorrhage, thrombus formation. Sequence of progression like this. Then main growth mechanism, growth mainly by lipid accumulation, accelerated smooth muscle and collagen increase, thrombosis, hematoma. Then from earliest onset from first decade, from third decade, from 4th decade. Then clinical correlation, clinically silent or overt. Advanced atherosclerosis. Advanced atherosclerosis. In established atherosclerotic plaque, macrophages mediate inflammation and smooth muscle cells promote repair. Cytokines released by macrophage starts degrading smooth muscle layered over plaque. Now lesion remains vulnerable to mechanical stress that ultimately cause erosion, fissuring or rupture of the plaque surface. Any breach in the integrity of the plaque will expose its contents to blood, trigger platelet aggregation and thrombosis that extend into the atheromatous plaque and the arterial lumen, cause partial or platelet obstruction at the site of the lesion, then distal embolization resulting in infarction, ischemia of the affected organ. Advanced atherosclerosis, stable angina pectoris, adventitia, endothelium, media, lumen, atherosclerotic plaque, then necrotic center, unstable angina pectoris, subtotal occlusion, thrombus, ulcerated fibrous gap, necrotic center, then myocardial infarction or STEM, thrombus and total occlusion of the lumen, myocardic center. Angina is pain which occurs in these areas of body when your heart muscles doesn't get enough oxygen-rich blood. So introduction, a type of chest pain, not a disease. It's a symptom of an underlying heart problem, specifically IHD, ischemic heart disease. They describe as heavy, tight or gripping. Typically central retrosternal, middle ache to most severe that provokes sweating and fear. Associated breathlessness. Then functional classification of angina. Class 1, no angina with ordinary activity, angina with strenuous activity. Angina during ordinary activity, walking up hills, walking rapidly upstairs and mild limitation of activities. Angina with low levels of activity, walking 50 to 100 yards in a flat, walking up one flight of stairs with marked restriction on activities. Angina at rest or with any level of exercise. Classical or exertional angina pectoris, categorized by constricting discomfort in the front of the chest, arms, neck, jaw, provoked by physical exertion, especially after meals and in cold, windy weather, or by anger or excitement, and relieved usually within minutes with rust or glyceryl trinitrate. Occasionally, it disappears with continued exertion, walking through the pain. Typical angina, all 3 features. Atypical angina, 2 out of the 3. Non-anginal chest pain, 1 or less of these features. Types of angina. Stable angina. Stable in the sense episodic clinical syndrome where there is no change in severity of attacks. Then unstable angina. Angina in the sense deterioration 24 hours in previous stable angina with symptoms frequently occurring at rest. Acute coronary syndrome. Then refractory angina, patients with severe coronary disease in whom vascularization is not possible and angina is not controlled by medical therapy. Stable, unstable, refractory, acute coronary syndrome. Then variant, Prinzmetal angina occurs without variant angina occurs without provocation, usually at rest as a result of coronary artery spasm or more frequently in women. And management of angina pectoris involves careful assessment of the likely extent and severity of arterial diseases, then identification and control of risk factors such as smoking, hypertension, and hyperlipidemia, use of measures to control symptoms, identification of high-risk patients for treatment to improve life expectancy, then medical management, antiplatelet therapy. So management of angina pectoris involves careful assessment of the likely extent and severity of arterial diseases, then identification and control of risk factors such as smoking, hypertension, and hyperlipidemia, use of measures to control symptoms, identification of high-risk patients for treatment to improve life expectancy. Management medical. Antiplatelet therapy. Low dose 75 mg aspirin reduces the risk of adverse effects such as MI, then prescribed for all patients with a CAD indefinitely. Then clopidogrel 75 mg daily, equally effective alternative. If aspirin causes dyspepsia or other side effects. Anti-anginal drug treatment. 5 groups of drug. Nitrates, beta blockers, calcium antagonists, potassium channel activators, and IF channel antagonistics. Beta blockers, nitrates, calcium antagonists, then potassium channel activators. The nitrates act directly on vascular smooth muscle to produce venous and arteriolar dilation, reduction in myocardial oxygen demand, increase in myocardial oxygen supply, then prophylactically before taking exercise that is liable to provoke symptoms, then continuous nitrate therapy can cause pharmacological tolerance. Avoided by a 6-8 hour nitrate free period. Then nocturnal angina, long titrating nitrates can be given at the end of the day. Then beta blockers lower myocardial oxygen demand by reducing heart rate, BP, and myocardial contractility. And calcium antagonists inhibit the slow inward current caused by the entry of extracellular calcium through the cell membrane of excitable cells, practically cardiac and arteriolar smooth muscle, lower myocardial oxygen demand by reducing BP and myocardial contractility. Potassium channel activators, arterial and venous dilating properties, but do not exhibit the tolerance seen with nitrates. Nicorangil, only drug in this class currently available for clinical use. Potassium channel activators. Then IF channel antagonist. Ivabradine is the first of this class of drug. Induces bradycardia of modulating ion channels in the sinus node. Apparently does not have any other cardiovascular effects. Safe to use in patients with heart failure. Then universal definition of myocardial infarction, MI infarction. Evidence of myocardial necrosis in a clinical setting consistent with myocardial ischemia, in which case any one of the following meets the diagnosis for MI. Detection of rise or fall of cardiac biomarkers, preferentially troponin, ECG changes indicative of new ischemia, new STT changes or new left bundle branch block, development of pathological Q waves, imagine evidence of new loss of viable myocardium or new original wall motion abnormally. Then clinical features, symptoms, pain in the cardinal symptom, prolonged cardiac pain, chest, throat, arms, epigastrium or back, anxiety and fear of impending death, nausea and vomiting, breathlessness, collapse or syncope. Then types of MI, there are 3 types of MIs. Type 1, spontaneous MI with ischemia due to a primary coronary event, plaque erosion. Type 1, spontaneous MI with ischemia due to a primary coronary event. So, spontaneous MI with ischemia due to a primary coronary event, plaque erosion, rupture, fissure or dissection. In type 2, MI secondary to ischemia due to increased oxygen demand and decreased supply, such as coronary spasm, coronary embolism, anemia, arrhythmias, hypertension or hypotension. Type 3, 4, 5, diagnosis of MI in sudden cardiac death after precutaneous coronary intervention or PACI and after coronary artery bypass graft CABG respectively. Then cause and pathogenesis. The multitude of factors are responsible for development of IHD. The major risk factors are smoking, diabetes mellitus and cholesterol levels. Those with hypercholesterolemia, elevated blood levels of cholesterol, have a much higher tendency to develop the disease. There is also the theory that hypertension is a risk factor in the development of IHD. Genetic and hereditary factors may also be responsible for the disease. Then males are more prone to IHD. However, in postmenopausal women, the risk is almost similar to that of men. Stress is also thought to be a risk factor, although there has been a great deal of debate on this factor of late. The disease progress occurs when an atheromatous plaque forms in the coronary vessels, leading to narrowing of the vessel walls and obstructing blood flowing to the musculature of the heart. Then complete blockage results in deficient oxygenation and nutrient supply to the heart tissue, leading to damage, death, and necrosis of the tissue, which is known as myocardial infarction or heart attack. And risks of this condition include personal family history of heart attack, angina, unstable angina, then atherosclerosis, or other coronary artery diseases, high blood pressure, smoking, diabetes, high fat diet, high cholesterol, obesity. In signs and symptoms, quite often the first sign of ischemic heart disease may be the severe chest pain or myocardial infarction, which may be fatal. The warning symptoms occur in a large number of patients in the form of angina pectoris. The main symptom of angina is pain over the central chest that may sometimes radiate down the left arm to the jaw or to the back. The characteristic feature of pain is that it is usually aggravated by exercise and relieved by rest, though variant forms may occur. The pain is also relieved by the use of nitrates kept under the tongue. Then the pain is usually described as a sense of compression or tightness in the middle of chest and may last for 5 to 20 minutes. The pain may be accompanied by sweating. The presence of anginal episodes is usually diagnosed by IHD. Symptoms: chest pain under the chest bone, may move or radiate to the neck, jaw, back, shoulder, arm, may feel tight, pressure, crushing, squeezing, may or may not be relieved by rest of nitroglycerin. Rust or nitroglycerin. Then sensation of feeling the heartbeat, palpitations, then irregular or rapid pulse, shortness of breath, especially with activity, shortness of breath that occurs after lying down for a while, then cough, fatigue, weakness, faintness, decreased alertness or concentration, decreased urine output, excessive urination at night, and overall swelling, breathing difficulty when lying down, along with some other symptoms. And then how to investigate this: investigations and diagnosis. Electrocardiography may be normal in several patients at rest when attacks of angina. During the episodes of pain, there may be depression in the ST segment and T-wave inversion in several leads, indicating ischemia. In cases of infarction, heart attack, there will be ST segment elevation in the ECG, which may gradually evolve. An electrocardiogram may help in showing any functional abnormalities in the various cardiac chambers and in assessing the pumping efficiency of heart. An exercise testing, treadmill test TMT, is often indicated in patients who have symptoms but have normal ECG patterns. Nowadays, TMT is being indicated at all high-risk categories beyond the age of 35, irrespective of symptoms. Myocardial perfusion scanned with radioactive thallium may also be helpful in the diagnosis. Coronary angiogram provides accurate information about the acute site and extent of the stenosis or narrowing, and helps in deciding the method of therapy required. Then treatment and prognosis. Drug therapy with nitrates, which dilate the diseased coronary arteries, administered sublingually, are very effective in relieving the pain in few minutes. Drugs such as isozobide dinitrate and isozobide mononitrate belong to the category of nitrates. These drugs are also used as a prophylactic to prevent the pain from occurring. Then beta blockers like propranolol are also highly effective in relieving pain by reducing myocardial oxygen demand, mainly by decreasing the heart rate. Then calcium channel antagonists produce vasodilation and relieve the symptoms of reducing the excitability and conductivity of cardiac muscles and by reducing blood pressure. For patients with hypercholesterolemia, drugs may be used to lower cholesterol levels. Then surgical treatment. Surgical treatment is another method. Surgical therapy is indicated when medical treatment has failed to relieve symptoms or when the angiogram shows significant disease in the blood. Decrease in the blood vessels. Coronary angioplasty, dilating the blocked vessel by inflating a balloon inside the vessel, and coronary artery bypass grafting. Replacing the blocked area of the vessel using a graft from the patient may be done to relieve the blockage. A number of studies have shown that heart failure symptoms may be improved with a special type of pacemaker if paces both the right and left sides of the heart. This is referred to as biventricular pacing or cardiac resynchronization therapy. A heart transplant may be recommended for patients who have failed all the standard treatments and still have very severe symptoms. Recently, implantable artificial heart pumps have been developed. At this point, very few patients will be able to undergo either of these advanced treatments. The indication for bypass surgery are increasingly becoming limited. This is due to the growing realization that except in selected cases, bypass surgery only helps to improve the quality of life and relieve symptoms. It does not significantly increase life expectancy. The current trend is to focus on medical treatment and techniques like angioplasty. With proper treatment, most patients will be able to lead normal and healthy lives. Treatment also involves advice regarding regular Exercise, avoiding smoking, diet control, and lifestyle modification. Good control of diabetes and hypertension significantly improve the outlook.